forms of history taking. One is your disease unknown. Disease unknown, disease known, and then your focus history taking. Okay. All of them very important. You must actually know what is your DDX differentials. When you start, okay, I'm gonna start. You must have a differential. If you are an MRCP, they give you that 5 minutes. You think they'll give you like, oh, patient has anemia. List down at least minimum 15 differentials to work on from different systems. Okay, let's start with disease known for the benefit of people who have not heard this before. Those who have like been following my teaching for like since forever and have heard it 1,000 times. Let's say you are diabetic, you are epileptic, okay, or you're asthmatic. Okay, these are all disease known. So I say, you will say, please take a history of the patient's diabetes, take a history of patient's epilepsy, take a history. So a lot of people, what they do is just jump straight into it, no structure, no framework, just ask. Then after a while, they cannot, hey, did I ask this? Did I not ask this? What else to ask? Then they stay silent because why? They're thinking of what else to ask. Okay, never jump into, when you go for exam, you see, your exam, your mind is already so luan already, so chelaru, everything all over the place. You're gonna go in with your chelaru mind, you're asking for disaster. You must go in with a framework. You forgot what to say, you just fall back onto your framework. Okay, so I'm talking about DM epileptic. Okay, so my framework will be, okay, what's the patient's? The framework is D2 FM C3. So patient's duration. How long have you been having this? When you first noticed this? Okay. Next one you need is a diagnosis. Okay. So your diagnosis, again, diagnosis is presenting symptoms. Hey, how do you know that you had this? Oh, I was thirsty peeing all time, itchy, chalap, and all that sort of thing. And then after that, what are your risk factors? Okay. Do you have any risk factors? Father, mother had it. Okay, grandfather had it, like drink Coca-Cola. And for epilepsy, asthmatics, ask for triggers. What are the triggers that trigger your epilepsy? What are the triggers that trigger an attack of your asthma? You may ask whether the patient has done gold standard investigation, epilepsy, have you done your EEG, done an MRI brain? For asthmatic, not all get a lung function test, spirometry. Alright, so a lot of them will just say, oh, I had childhood. Okay, if they don't have, then you talk about clinical criteria. Oh, I had childhood asthma, I have family history, I have atopy, I have diurnal variation. So they label me as a asthmatic. Okay, then where and who and where lah. Okay. Next, after that, your F is follow up. Okay, if not proper follow up, why? Why doctor shopping? After FM is
modification. No.
Management. What's the management? Whether you talk about lung cancer and all, what's the management? The non-pharmacological and pharmacological eye care, food care, diabetic counseling. Have you gone for diabetic support care and all that sort of thing? Group care. And then after that, what you're on metformin, basal bolus insulin, SGLT2 inhibitor. Okay, then some more, what else? Don't complete compliance. Are you compliant to your weight loss? Jaga makan. If you're not compliant, why? Okay, always ask why. Once you have your compliance, then only you know what is your control. Control how often you are admitted, how often you drop by the ED. Okay, how often you go into ICU already. Okay, what's your GNAP? If you're asthmatic, what's your GNAP? If you're diabetic, what's your SMBG at home? Okay, how often do you have uncontrolled DM? How often do you have your DKA, asthmatic, you nap in the clinic, you nap at home, okay, got nap machine at home, or how often, a lot of the patients don't get admitted, but they come to ED, nap, get better, go home already. But they nap every week, so that's poor control, isn't it? Alright, and then after that, finally, you end with complications. Complications, what kind of complications you will have? Disease-related and also treatment-related complications. So this is the framework. Forgot what you want to say, just fall back onto the framework, ask all these questions, make sure you have all these questions if you say lah. But nowadays you don't get so much to take a history of the diabetes mellitus, take a history of epilepsy, asthmatic anymore. This one is more for daily use lah. If let's say you're in the clinic and then they want a really detailed history, okay? The next one you have is your focus history taking. Usually you get this in your, again, you rarely get this in your MRCP. Back then they will say things like, oh, this patient has been referred, dear Dr. Yo, this patient has been referred from the general practitioner. Okay, noted that HB is 7.2. Please do the needful. So then they will come to your clinic. Then you will do the introduction. Hi, good morning, I'm Dr. Yo. I'm here to ask about your low blood. Okay, how would you like to be addressed? Before we begin, anyone you'd like to be reviewed? Okay, what do you know so far? And then focus. Usually focus history taking, again, you go straight from ask about the symptoms, how long you've been having your symptoms, how you're feeling tired, slow in walking. Okay, you ask your duration. Okay, but whatever is this, you go straight into your differential diagnosis. You start. Okay, so anemia, what kind of? So anemia, reduced production, increased loss, increased destruction. Okay, increased destruction. Has anyone say you look jaundice? Have you got any? Have you ever got joint pain, mala rash, photosensitivity? Have you ever had any family history of anemia? Anybody said that you have thalassemia in your patient, needed recurrent transfusion? Any member needed recurrent transfusion? Anyone has any blood problems before in the family? Are you vegetarian? If you're female, do you lose blood from anorexia? Do you need to take iron supplements? Okay, have you ever had a transfusion before? Did anyone tell you have lung cancer? Do you have cancer? Do you have cancer that spread everywhere? No, all these sort of things. So it's basically symptoms, how long you've been having, and you work through each of the differential diagnosis until you get what you need. So focus history taking, again, used to have it, you don't get it very much anymore. Okay, because nowadays most of them will be the symptom of the unknown. So patient has SOP, take a history. Patient be feeling tired, take a history from this patient. So these are all your unknown. You know that the patient, this is the symptoms, but I don't know what is the cause of the symptoms. Okay, just before I begin this, just short, okay, what's the difference between relevant, negative, and associated symptoms? What's the difference? We talk about associated symptoms a lot. They say everyone comes in, oh, patient feeling short of breath, no urinary tract infection symptoms. Huh? Are you sure? Do you really need to say that? No? Anything? Associated symptoms are symptoms or group of symptoms that, when positive, ruin a diagnosis. Okay? Relevant negatives is symptoms, group of symptoms that, when negative, they rule out a diagnosis. So one rule in, one rule out. So if let's say the patient comes with chest pain, 65 years old gentleman, left-sided chest pain, associated with radiation to the neck and also to the left shoulder, nausea, vomiting, palpitations, diaphoresis, leg swelling, orthopnea, and PND. No fever, no cough, no greenish sputum, no tearing chest pain radiating to the back, no uncontrolled hypertension. Alright, no epigastric discomfort, retrosternal burning sensation, no acid rash, no water rash, no unaccustomed exercise or unaccustomed activity, no vesicles, and also tingling sensation in the chest dermatomes. What did I just do?
Associated symptoms and negative.
I put in the associated symptoms for ACS. I also put in relevant negatives for pneumonia, okay, gastroesophageal reflux syndrome, musculoskeletal pain, and also herpes zoster infection. But of course, for the exam, you do more of this stuff. You cover, and also I rule out aortic dissection because I said no tearing chest pain, uncontrolled hypertension. Okay, so you see, I'm very systematic. By this systematic, you can even see the logic. Is that I don't just randomly put no this, no that for the fun of it. The nose must be a symptom of one of the differential diagnosis. That is how you know that this is a relevant negative. Don't just put patient coming in chest pain, no UTI symptoms. Huh? How is it related? Doesn't make sense. Has to make sense. Must be one of the symptoms of the differential diagnosis. Then only you can say it's a relevant negative. Alright? Faham tak faham? Easy peasy, isn't it? Okay, so let's say I don't know what is the patient's symptoms. What am I gonna do? I'm gonna use the traditional presenting complaint plus duration. Okay, history of presenting complaint. Okay, sorry. Okay, what else? Past medical history, past surgical history, okay, family history, drugs and allergies, okay, and social history. Alright, so this is your traditional that you have always been taught. Now, unfortunately, you've been taught this, but I can't use this for the rest of these. Okay, when you talk about history, focus history taking, family history, yes, it's important if you're talking about anemia, but you ask it as part of your ruling out the history of thalassemia. So you ask about the family history. You don't ask family history as a separate problem because patient may have a problem that is unrelated to the focus history taking. When you focus, you just talk about the symptoms, duration, and then all the differentials, and you're just ruling out because this is focus. Nowadays, these are rare in MRCP, they're usually this because then this one you can. So you must again have a framework. If you forget what you want to ask, just ask the rest of the things that's in the framework. Okay, don't waste your 40 minutes. Don't sit there, look at the examiner, look at the patient, put your mouth like that. Please don't do that. Just start asking the past. Because sometimes a lot of the thing that clinch the diagnosis is always sitting in the social history, especially for respiratory diseases. Oh, patient's hobby. Oh, I keep parrots. Oh, I keep pigeons. I have 100 pigeons and I have a pigeon house. Yeah lah. So that's the cause of his progressive shortness of breath lah. Okay. So if you don't know what to ask in the history of presenting complaint, just go to the rest and go through that. All right. So we're gonna go through one portion by one portion. So presenting complaint, what must you do? Let patient talk. Please never interrupt patient. They'll give the 2 minutes is important. Patient stop, then you start talking. If it hasn't stopped, if let's say patient talk for 1 minute, stop, and then any other things you want to add, you must encourage so that you use up the 2 minutes. Don't start talking within that 2 minutes, they don't like it. After that, what are you gonna do?
Clarify.
Yes, clarify. Because patient tell you saya mengah. What is the definition of mengah? In Malay, mengah, shortness of breath is mengah, reduced effort tolerance is mengah, wheezing is mengah, every damn thing is also mengah. Okay, clarify the symptoms. Let the patient talk and then you report in the patient's own words. Patient claims symptoms of mengah or feeling short of breath. I've asked for further details. The patient actually claims that it is a whistling noise, okay, polyphonic, especially at 2-3 a.m. in the morning. So what does that tell you? Patient either has an asthma or COPD, isn't it? Okay, and then how long the patient been having this? So you got the duration. Alright, then after that, what must you do? Next portion, your HPC. HPC actually has 2 components. HPC is a bit like your focus. In fact, the focus is a subset of the HPC. Okay, but if you just ask focus history taking, you're not testing the rest of the things, so that's why they don't like to use focus history taking and all. So 2 components of HPC. What's the first part of HPC and what's the part 2 of HPC? First part is your characteristic of the symptoms. Now that you know you have clarified already, the patient is talking about shortness of breath and not wheezing, or talking about wheezing and not shortness of breath. You have to find what is the characteristics. Then only the second, you work through your differential diagnosis. Okay, working through the associated symptoms and finding out what are the relevant negative. So you see, over here you must have your differentials, over here you must have your differentials. Alright, so characteristics, how do you describe the characteristics of the symptoms? different people got different, like people use pain. I use some people use Socrates, but Socrates is only valid for pain. So I expanded on that. I use Oppa, and then after that, depending on what symptoms they have, I have other symptoms as well. So Oppa means onset, sudden, gradual, subacute. P means progress. So progress, you have severity. Okay, what else? Symptom duration. When the chest pain comes, how long is the chest pain? When the chest pain, then you talk about symptom-free duration. When you have no chest pain, how long does it last? Oh, I got no chest pain. It lasts for a few hours until I start walking again. Then I get the chest pain. Okay, then you get your time association, or happens more in the middle of the night, happens more in the morning, early morning. Alright, when the severity is going up, people come to hospital. Symptom duration going up, people will come to hospital. Symptom-free duration going down. Okay, oh, actually 3 weeks ago it was once a day the pain, but now it is every hour also I get the pain. Okay, and it's lasting longer and longer. This will cause people to come to hospital. Alright, the next P is previous similar episodes. Have you had previous similar episodes? Okay, and then is the pain similar? If it is similar but less severe, okay. I used to have, I had this 3 years ago, and it was less severe, but now it's very, very severe. So you know, and what was, I was admitted and they say that I have a heart block or something like that, or one of the blood vessels was blocked. Then you know that patient had previous similar episodes, now it is worsening. Okay, and A is aggravating and alleviating. Okay, the characteristics. So if let's say I have other things, okay, so if let's say the patient has pain, what must I add on? If the patient has pain, I must add on site, radiation, and character. So whether it is head pain, heart pain, chest pain, abdominal pain, back pain, leg pain, all must have site, radiation, character on top of onset, progress, previous similar episode, aggravating, alleviating factor. Okay, and then you think of the differentials, then you work through all the differentials. What are the symptoms of each of the 2-3 symptoms from each differentials? What other symptoms would you have? Sorry?
Secretions.
Bodily fluid. Excellent. So bodily fluids. Bodily fluids include vomit, urine, feces. Okay, so feces include diarrhea, constipation. Okay, so you must ask about their volume. You must ask about, on top of all this onset and all volume, you must ask about the content. So is there blood? Where there is blood, you must also ask whether there is any clot, whether there's any pus, mucus, bowel, grease. Okay, all these things are very important. Some more, what else? Okay, association with fasting. If you fast, will it go away? If not, okay, then what are other things? You have urgency. If you have to go, you really have to go. Alright, and if let's say you have polyuria, patient with polyuria, you ask them whether they have nocturia. If the patient is coming to you with hematuria, you ask them whether they have is before, during, or after the urination. So this is where your bodily fluid. Okay, constipation, diarrhea, how do you determine severity?
Bristol stool.
Yes, Bristol stool chart. It's not the frequency. Frequency is frequency lah. Bristol stool chart. Okay, 4 is normal. Okay, 5, 6, 7 heading towards worsening diarrhea. 3, 2, 1 worsening constipation. Okay, so that's how you deal with bodily fluid. What other nonsense do you have to deal with? Symptoms.
Behavioral, like syncope.
Okay, fine. So you have your syncope, loss of consciousness, delirium, okay, seizures, pre-syncope. So you ask about the prodrome. Okay, precipitating factor. I was standing for more than 1 hour, then I feel very tight choking. Okay, I feel sweaty, and then the curtains covering my eyes. Whether you have any falls, whether you have any injury, what is your recovery like? Okay, I was numb for 1 hour before, or I was weak for 1 hour before the strength come back to me, and that's like the toss paralysis. Seizure, then you want to know what seizure type, not just only general tonic-clonic. Some people are atonic, some people are myoclonic, some people are tonic. Just because you got no uploading of eyeballs and jerky movement doesn't mean that's seizures. There are lots of other kinds of seizures. Okay, and then you talk about incontinence. Alright? Okay, what other things? So you have palpitations. When you talk about palpitations, you talk about precipitating factors. I drank coffee and then my heart went pop, 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 pop. Okay, rate, and you have talked about rhythm. You may have also dysphagia. So when you have dysphagia, you have type, what type of liquid, solid, initiation of swallowing, any problems in initiation of swallowing, and then the site of stuck, where they stuck halfway, stuck in the throat, stuck almost to the bottom. Okay, what are the things that will cause your, what are the things that possible cause? Some things like, you know, shortness of breath and all, you just use OPA, it's more than enough already. But if let's say you have other things like here I mentioned, then they need an extra bit of questionings. Okay, what other things? You have lumps, bumps, okay, mass. So when you have lump, bumps and mass, okay, so what you ask about the number, you ask about the site, you ask about the surface, okay, the borders, okay, whether it's tender, okay, mobility, okay, consistency, okay. So those are lumps and bumps. Okay, what other things? Let's say you have numbness, weakness, joint pains, leg swelling, cold hands. So on top of OPA, you also ask about the
Distribution.
symmetry and distribution. The distribution where left leg up to the knee, right leg up to the ankle only. So asymmetrical. And finally, you end with your
Rashes.
weight loss, okay, or weight gain. So again, this one you must know your amount of weight loss, weight gain, over what time period, okay, whether it's intentional, unintentional, what is your diet like, okay, fruits, veg, meat, dairy products, okay, number of meals, maybe they are so poor they only have 1 meal a day, okay, number of meals, alright, whether you're vegetarian or not, okay, stay alone, nobody cook for you, okay, and then you'll talk about physical supplements also. Are you talking about taking vitamin C supplements on Ensure? Okay, and physical activity. Some people eat normal, some bulimic patient, anorexia patient eat normally but run a marathon every day because they want to lose weight. So these are all the possible symptoms that you may get. Start with asking the OPA, then you say palpitations, ask all these rest of the things. Then you are just only done with the characteristics, first part. Okay, second part, you already know I'm asking about constipation, so I'm sure I have like at least 10 to 15 different causes of constipation, whether patient is hypothyroid, patient has a GI malignancy, okay, patient has poor fiber, poor diet intake, okay, all those sort of things you keep on asking, patient dehydrated, electrolyte imbalance, so you just ask. So you should never ever run out of things to ask. If you have a framework, your 14 minutes will just seem so short. I think a lot of times the people, their problem is they ask us for 10 minutes, suddenly nothing more. 4 minutes looking at the patient, looking at the examiner. It looks very unprofessional. They cannot speak. You must be like all the questions, never non-stop. Okay, like this, you think this ask this much with the differentials, at least 7 to 10 minutes, and then you still haven't finished all the rest. If you forget suddenly, your mind blank, don't know what to ask, jump into your past medical history, past surgical history, where you can use disease known. Patient had a history of breast cancer. Then you have to ask lah, okay, have you used any, what was done, did a mastectomy, how do you first know? Okay, I felt a lump there. Father, mother also had the breast cancer. Okay, and then was given anthracycline as part of the chemotherapy drug. Now present with shortness of breath. So you already know breast cancer, anthracycline, cardiomyopathy, decompensated CCF causing shortness of breath. Usually nowadays they play this kind of tricks one. So there will be something hidden. So you forgot to ask about the breast cancer. Let's say you forget to ask about past surgical history. Then you get the same. They will keep on asking. Okay, fine. So the patient had you get the symptom of heart failure. You think, wow, good, I got the symptom of heart failure. Then they ask you why. What's the differential? And you keep on giving, and keep on. Some more. What other differentials you have? And because you forgot to ask about the past surgical history, you fail because you cannot get the fact that the patient had breast cancer and then was on anthracycline. So that's why there will always be it's very easy to get the main symptom, okay, and then you get the differential heart failure. Then they ask you why the heart failure, and then it's like crap. Forgot to ask about the history. Maybe the patient had a thyroidectomy. Okay, patient had thyroidectomy done before, so patient chronically hypothyroid, always non-compliant, leading to the heart failure. Or the patient has been patient is known to be hyperthyroid, toxic multinodular goiter, however so afraid of treatment, defaulted, and now presenting to you with thyrotoxic cardiomyopathy. But if you don't ask about the other medical history, then you will not get it. You only get the heart failure. You think you pass, but actually you don't pass because you don't get the rest. Okay, family history, make sure you build at least 3 generations up to the grandfather. Drugs, allergies, this one TCM, don't forget to include. Social history, this is the one. Again, social history is if you ask me, the past history of presenting complaint and the social history will be the 2 most important part, because the clincher is always somewhere in the social history, especially if it is a respiratory symptoms. Must be some history or some pyrexia of unknown origin, must be something in the travel history, something in the hobbies history. Yeah. Okay, so social history. What's the social history? What's the most important social history to ask?
Living condition.
Married, not married. If you are a guy, you're married, you're gonna live. Colin is gonna live longer than you. Okay, because you got someone to take care of him. Okay, married, not married. Health of spouse. If the auntie has a BKA and then got diabetic retinopathy, partially blind, uncle is 90 kilos and has a stroke, then right hemiparesis. How is the auntie going to move the uncle around? You have to, if you discharge the uncle, is going to get a bit sore and die. You have to refer to a nursing home because auntie is not healthy, so it's not capable of taking care of uncle. Then next question.
House condition.
Children, where are they? What's their job? All 3 are lawyers. You die also make sure the patient survive. Okay, where and the job. And then, are they willing to help or not? Sometimes they are all pieces of char siu only. Okay, some more what else? Living conditions. Okay, so I'm going to look at the accommodation. Okay, so accommodation, what is the house like? Okay, what's the toilet like? And amenities. Got electric, got water, got toilet, or it's just a hole in the ground. Okay, some more what else?
Working condition.
Occupations. This is occupation. You cannot just pensioner. Pensioner is not an occupation. What was the patient? Maybe the patient was a gigolo for 30 years before that, but now he's a already. So what? So pensioner, so what? But you were gigolo before that for 30 years, right? Sure got HIV already lah. Occupational and financial status. Okay. A lot of times you see the problem in Malaysia. Pensioner is for someone who work in the government, retired at a age and then receive pension. They mix up retiree with pensioner. A pensioner is not a retiree. All pensioners are retirees, but not all retirees are pensioners. Okay? Malaysians don't understand that. So you have to be careful. Okay, financial status, and then we'll go GPA cover. Yeah, you're a pensioner also, but you're low ranking, so you don't cover lah. You retired as the Dean of University Malaya faculty, then of course lah, you got more coverage than the guy who retired as a PPK lah. Okay, some more what other things?
Hobby.
Hobbies. Remember, a lot of things are here. Hobbies, travel. Okay, eat street food. Went to India, eat street food. Come back now, chronic diarrhea. Okay, some more. Don't forget your ADL, activities of daily living. Can you comb hair, go to toilet, change berak, pakai baju, go and buy your own groceries, go repair your house, take a bus, make a telephone call, and then finally QOL, quality of life. How's it affect your quality of life? How do you feel? This is where you put in your ICE. What are your ideas? What are your concerns? What are the expectations of this disease? Okay, and then that's it. That is your history taking for disease unknown. So if you have a framework, you are not afraid. Sometimes if you run out of things to say, quickly go to the social history and start asking all these things. And then once you suddenly occupation, yeah, I was a stonemason and I was using a lot of breaking down rocks in the quarry. Suddenly then you go back to here. What questions to ask in your differentials already? Because the fact that I have 200 pigeons that I raised and then I have a giant pigeon house. Okay, fine. Then I know what to ask in my onset progress, previous, and then aggravating factor already. Okay, do you have wheezing lah? Do you have no symptoms lah? Do you feel that you have reduced effort tolerance lah? Okay, so sometimes if you stuck here, jump here. Alright, but you should never run out of things to say. You should hit your 14-minute mark and still asking question. Okay, but I think usually by the 7-8 minute, if you have a clear differential about 10-15, you know that you're closing in on one already. Okay, so like I said, you never seen this patient before. Okay, it's totally blind to you. So if you go in all over the place, you're not gonna get the diagnosis. But if you go in systematic, you have a framework. No matter what case, you are not afraid. You can handle any case. Okay, guys. PACES is gonna be great, right? Station 2 is easy peasy, right? But you must make sure you know your differentials. So a lot of times I spend is writing out differentials and memorizing them. And if you look at your OST, right, there's only 30 to 40 possible symptoms. And like chest pain, we are really masters of chest pain. Headache, what you can't talk? Central, non-central, the primary one. So migraine lah, hemicrania lah, then you have all your tension headache lah, cluster headache lah, then on your SUNCTs lah, neuralgias lah, and then after that you're going through the peripheries, temporal mandibular joint problem, otitis media, sinusitis, occipital dislocation, cervical myelopathy, okay, neck pain radiating up to the head, dental problems, okay, acute angle closure glaucoma. See, it's not like it's a lot of it is experience, but if you write it down, you'd say, okay, if I have this, I ask about symptoms of this. Because a lot of times they give you a headache, then you ask, oh no, then you get frustrated because say, oh no, aura lah, no this lah, no that lah. Okay, but you didn't ever ask him hello. Is that hello? Oh yes, there's a hello. Once you ask hello, diagnosis clincher already. Acute angle closure glaucoma. Temporal arthritis lah, when I chew, I get tired. Okay, I got shoulder tiredness at the end of the day. But then you ask but you see, all of us always hit migraine one, isn't it? Oh, any problem? No. When the patient say everything also no, then you get frustrated because your first 3 already rule out already. Then you must make sure you have a backup of 10 to 15 so you get move further down and further down. And it's always something that nowadays is something that's 8 or 9 on the differential diagnosis, this one. So if you only know 5, that's it. You are finished. You won't score for history taking already. Okay? Right. Great. Thanks, guys. Okay, I hope you all enjoy yourself, learn something new. Okay, we will see you again next week. Or next week, this week I'm a bit busy. Next week lah. Okay, so next week, what do you all want to learn? You all put in the group lah. You all go and vote and put one in your group lah. Okay, then we should talk about all the different techniques of.
Is there even voting? Got voting right?
You put in the group what you want to learn lah. Okay, you can take picture and send to